Hey there.
Hi.
Hey.
Cutie.
Hey. So we're doing Wednesday lesson of the day. The first part of the lesson is photography. Ritu Chopra, my friend here, is an amazing surgeon, terrible photographer. So we are showing him how you can use lighting to flood your face. And if you tilt up a little bit, you don't see any under eye bags. But then if I go the other way, you'll see some under eye bags. So today's lesson of the day, the pattern today was this. I saw lots of patients with overfilled chins. I saw one patient who had a major complication with a chin filler. And, there was another patient who we were talking about who had some complications from a chin filler. And then recently I saw a post from Consultant Clinic, I think, another doctor, I forgot who it was, but they treated complication that happened from a chin filler elsewhere. So today's about chin fillers and chin augmentation. First, let's talk about where the chin is supposed to be and what it's supposed to look like, because chin implants are overdone 90% of the time. 90% is a very high number, and it's about right in the world of plastic surgery, if you're wondering, because if you look around, people don't look great all the time. So the chin implants are overdone 90% of the time. And it's because most doctors don't know how to understand or don't understand the aesthetic of the face. And what they use is algorithms and research articles from the past which try to describe what the chin should look like without actually looking at the face. So they go and look from the side view and they say, well, if you have a prominent nose, then you have to bring the chin forward to match the nose. Or if you have prominent lips, the chin's supposed to be at the level of the teeth. So there are these different equations that you could look at that show the slope of where the chin is supposed to be, but they're all incorrect. They're good as a general guideline to understand the face, but they are not a hard and fast rule. But it is helpful to think about things in the way where the upper lip should be a little bit more forward than the lower lip and slope back to the chin. That makes sense. However, the equations are wrong because they don't take into account tooth position, nose position, position of the maxilla, or anything like that. So if you have questions, by the way, put them down in the question box over there and I'll answer as we go through, because I see some questions about chin implant and bone resorption, which I will get to. When we're looking at the face, you have to look at the side as a saucer. And you have to assume that most people have a normal forehead. And most people do, even if they don't have a normal nose or maxilla. So it's more likely that someone's forehead is normal in shape than their nose and their maxilla. Which means instead of using the nose and the maxilla as your point of reference, you have to use your forehead. And you look at the whole head like a saucer. And if you look at it like a saucer, it should be like a little satellite dish. And the chin should kind of fit into that satellite dish. All too often you'll see somebody looking over and thinking that they need a chin implant because they have a short cervical mental distance, when in fact they need to go that way. Or they think they need a chin implant because the teeth are too prominent and they have these teeth that come out to here and they think the chin is small. And instead of bringing the teeth back, they have a prominent teeth and they make a prominent chin. Now they're prominent lower mouth. What do they look like? That's right, an ape. So you don't want to do that. You don't correct. Two wongs don't make a white. So you don't want to do prominent, just to balance things out. It doesn't make sense. You have two prominent. So you really want to look at the chin as a saucer and see if it matches. And then look at the position of the teeth and the nose and see, are they in the right position or are they too far forward? And then look at the neck and say, is this distance going back to your hyoid and to your mandible, the gonial angle, proper? Or does it need to go in that way? I like to keep people more delicate, so I avoid chin implants in the large majority of them. However, I still do chin implants, and I do them well. And the reason I do them well is because I like to keep women feminine, I like to keep guys masculine, and, well, if they want to do different kinds of surgery to make them feminine to masculine, masculine to feminine, that can be done too. I'm not that good at that. So when you look at the chin from the front, you also have to look at the breadth of the chin, how broad it is, and to see if you make it wider or narrower. When you do a chin implant, and if you do a chin implant, they're usually placed from under the chin. Some people place from in the mouth. Most of the problems that you see with migration and improper positioning and those kind of things are done from inside the mouth. The reason for that is because the same people who do it inside the mouth also don't know how to properly do it. So they end up putting it in the wrong area, they put them too big, they resorb, a lot of stuff happens. So why did chin implants cause resorption, which was one of the questions? Because they're too big. It's not because it's placed under the periosteum or over the periosteum or anything like that. It's because they're trying to achieve too much with a chin implant. Chin implant is meant to give a little bit of augmentation, a little bit of projection, and that's it. If you put a big chin implant, large, extra large, you're going to be pushing against the chin for years with all that pressure, and if your skin and your subcutaneous tissues and your muscle doesn't expand, then it's going to push in against the bone and you get resorption. So that's how resorption happens. It does happen more rapidly, most likely if you're under periosteum. However, it can happen in both situations. So it's usually because it's a large implant, not because it's an implant. Small implants generally don't resorb. Medium, less so. The bigger you get, the more likely resorption you get, and that's that. So resorption means that the bone is pushing into the chin, and the chin bone the implant's pushing into the bone, and the bone starts to remodel around it, which means you get little bony spicules and a ledge, and then this part goes in. So you put an implant that big, starts to recede over time. Put a smaller implant, that won't happen. So what happens if you need bigger movement than that? You don't do an implant. You send them to an orthodontic surgeon, and you do a sliding genioplasty. You do other types of sagittal genioplasties or advancements. Now, to the part that I was talking about, which is chin filler and what I saw today. So I saw a patient today who came in and she had telangiectasias or rosacea all over her chin, which means she had spider vessels here with a nice little translucent gelatinous glow underneath. What does this mean? Why does it happen? It means that she was injected superficially under the skin, and this area very quickly gets congested and irritated and starts forming spider vessels, or the vessels that exist in the capillary bed or network of the dermis, called the dermal plexus, start to engorge, and you start to see through them, and you see through them more than usually because there's a gel layer underneath, and it changes the refraction and reflection of light as light goes through and bounces back to your eye. So you end up seeing a whiter color here, and then more little spider vessels as they go, and they're usually striated, which means they go in little stripe pattern outwards like this radially. They don't go in different directions. They usually do that. That's because the filler was placed too superficially, and which filler is the most common for this to happen with is Juvederm, the classic one, because it tends to cause that issue by drawing in more water than the other fillers do. The other fillers can still do this, just to a lesser extent. Either way, the point of this is that chin augmentation is usually supposed to be bony. So the front of the, over here, if you see, it's not a lot of soft tissue. And if you have a lot of soft tissue, it turns into a witch's chin. It gets doughy, you get a fatty chin, and fatty chins are not delicate, they're not elegant, they're not nice. So you want to do bony augmentation here, which means you put very small amounts on the bone there, and it starts to push it out. Now, you can do a little bit going into the muscle there, but you will affect its function somewhat. Understand that when you inject into the mentalis muscle, you soak it, it doesn't function as well, and the chin again gets this kind of more lax appearance, and you get small minor changes in movements of the lower lip that nobody even looks at, but they exist. It's just you're not trained to look at it. I am, because when I see it, I'm like, something's wrong with your mouth. But it's from that overfilling, not on the bone, but overfilling into the muscle. Overfilling superficially on the skin gives you telangiectasias. This is why when you inject on the chin and you're an injector, you just get a needle, you go straight down, you inject on the bone. When you inject on the bone here, your risk of vascular compromise in this central portion is almost zero. Now, where do you get issues if you inject on the bone there is if you do boluses and you get a ball of gel that's in there and it can encapsulate and then it just never moves properly because it's stretching out the muscle again too much. Or what happens most commonly is that the injector doesn't put their thumb under here and the injection goes all the way into the neck. Why does that happen is because when we're injecting, we're trying to inject people on the lowest point here of the pogonion over there. And if you inject on the lowest point over there, there's a good chance that it's going to go into the neck over here and they start to develop a little bit of a chin like that. Now, compound this with many of the people you're injecting are getting injected because they have prominent teeth. Remember what I said? When you see someone with prominent teeth, you'll automatically want to push their chin out to match the prominent teeth. That's not the only reason why. The other reason why you inject people's chins who have prominent teeth is because when they have prominent teeth and the upper lip is up here, the lower lip to close has to go like this. And if you see, if you're always like this, your defining point of the chin goes higher and the bottom part here on the chin flattens. Now look at my neck. Now I get a rounder shape to my neck. So what happens in these patients is they are already prone to flattening here. They get more projection up here. So you try to augment them here. And their neck is already worse because they've chronically been doing this, and they get a slope neck, just like that. And then you go inject them here, and the filler goes in there, and then it gets worse. So these patients are particularly prone to this happening, and you can prevent it just by putting your finger there. But be aware of it, because you might need to go dissolve that. Now, where do the vascular complications come from? The midline? No. They come from the paramedian. If you go to your first and second premolar, and somewhere around them, you move down over here, and you feel the jawline. Now you go up, there's an indentation there. You can feel it on everybody. There's an indentation right there. That is your mental foramen, where your V3 and your vascular bundle, neurovascular bundle, come out of. And you can feel it on everybody. So you can feel it on the under eye when you put your finger in the under the iris itself, and then you come down into this little divot. That's where your V2 is. If you go on the medial side of limbus up, you'll feel usually a notch or a foramen right here on the medial side of the eye. For the chin, it's a little more lateral. You put your finger right there, you go up, and you'll feel an indentation. That is where the blood supply comes out of your alveolus to the mental foramen. You also have a facial artery that comes out in the soft tissue over here, but it's lateral, and it is deep to your platysma, so it's not under the skin. There's a little notch you can feel right here on the halfway point. It's in front of your masseter, which is here. It's right in front of it. That's the facial artery. So most people, when they're causing vascular issues, they're doing it from the mental foramen. And this happens for two reasons. One of them, and the main reason, is because you're injecting directly at the mental foramen. The other is that you're injecting near the mental foramen for a recurrent branch that can come down into the neck. So you can get vascular compromise in the neck from this, or you can get it in this region over here, in the entire region. This is why, or one of the reasons why, that you don't inject on the bone laterally. Also because most of the issue when you go laterally on somebody is in the hypodermis. When you look at somebody from the front, the chin is a bony type of augmentation. When you look at them from the side, there's a divot here in what we call the pregial sulcus, where the mandibular ligament is, and most of the augmentation you do there is actually for soft tissue depression. Under the skin, there's a hypodermal fat layer, which is this tiny little balls of fat. Below that is usually a SMAS layer, which here is very thin. It's longer cells of fat. Below that's the muscle. When you get older, you lose volume there. It indents. It starts to get darker because you're reflecting light directly to the muscle, which is burgundy, reflects back out to you. So not only do you have an indentation and a shadow from that, you have a shadow from the darkening. So what you do here to fix it properly is you actually have to go in the hypodermis. You have to inject under the skin here in order to get the maximal amount of brightening. It's also the highest yield way you can do it. It's also the safest. So for safety measures, it's another reason. So there's multiple reasons why. You inject here on the bone, and you inject here right under the skin. If you inject here on the bone, very low yield, very hard to get in the right place, and you're not correcting the real problem on the side, which is soft tissue deficiency and sometimes camouflaging drooping. So it's always better to do that. If you're going to use a filler, the best fillers to use there are hyaluronic acids, so you can dissolve them if anything happens. If you want to use the best filler in these areas, I like to use firm ones. You can use Voluma. You can use Restylane Define is a great one. You can use any of them actually, but those are my two favorite because they're firm and they are the more linear type of technology for cross-linking. So they actually go in there more smoothly without any issues. What else? So color correction. What do you do about the telangiectasias once you get them? You got to dissolve it. If you dissolve this area, what happens? You get something called peau d'orange, orange peel, which is cobblestoning, pebbling of the chin, hyperflexion when you have no volume there and you start to see the connections from the skin down to the superficial attachments to the mentalis muscle. And that's the difficult part about dissolving that area, and why I hate dissolving superficially there is because if it's been expanded for a while and then you thin it, you've thinned that already thin layer of SMAS that's there by dissolving the expanded tissue that was there, and you end up getting cobblestoning. You also have the vessels to deal with, so you have to use a laser. And I was talking about lasers today. The red lasers are in the blue spectrum, right? So you have the 532, 577, 595. Those are your red peaks for absorption, which means you can use a KTP laser like a diode. You can use a yellow laser. You can use a filtered IPL, which can actually go into that range, or a 595 is a pulse dye laser. The deepest of all of these with the biggest spot size is a pulse dye laser. So the best one to use, in my opinion, when you're doing this is the V-Beam Perfecta or the newer V-Beam. And you want to use a spot size 10 millimeters or greater because they get bigger depth of penetration when you're dealing with those things. So higher wavelength, higher spot size, deeper penetration, and you get better resolution of the telangiectasias. However, you can treat it with really any of those red lasers, but they will come back unless you get rid of the filler superficially there. And that gel color, which makes your chin look white, it's going to be there unless you get rid of it. Once you dissolve it, it gets darker, so you may have to refill. And that is the lesson of the day. You can also put Botox here if you need to calm the chin that's always contracted, to drop it down. When you're looking at the chin, just realize you have to look at the chin like this. Sulcus mentalis is here. The bottom of the chin is here. You grab the chin, cut it in half. Below this area, you can put Botox. Above this area, you cannot put Botox, or else it's going to affect the movement of your mouth. These areas over here, laterally, if you put your fingers down and go diagonal about 45 degrees, is your depressor anguli oris muscle. It usually splays out a little bit here. And then here you have your depressor labii inferioris muscle, which is the muscle that shows your teeth. This muscle pulls down your smile. So there are two different muscle beds over there, and you can Botox those to do different things as well. So now, let's go. Oh, so Karan Chopra here says, yes, Karan Chopra says, I look so good because of the flooding of the light, which I just taught your cousin here, Ritu Chopra. We got to teach this guy, man. He's an amazing surgeon, but he could do better photos.
Okay.
Yeah. So what about fat transfer to the chin? Amazing question. Fat transfer to the chin makes the chin look fat. In general, it makes it doughy, and it can give it a witch's chin, and it's very hard to fix. However, can you do little tiny bits of injection there? Yes, you can. I do it sometimes. When I need a really, really, really small amount, I put a little bit right here onto the bone, and it actually works out fine. Laterally, I do it all the time. Super, super common for me to fill the pregial sulcus where the mandibular ligaments are, and that's something I teach in surgery all the time. Most surgeons do not understand what the mandibular ligaments are. So most surgeons confuse this. They think it's a ligament that formed magically over time. It is not a ligament that formed magically over time. It is a set of reticular connections between the skin and the muscle that has always been there. It's just you start to notice it when it collapses because it indents now. And when you move things, you notice it more. All you need to do is reinflate it, and you don't need to cut it. Cutting it never fixed it. Cutting it gets rid of tethering if you medialize someone with plication. Otherwise, cutting the mandibular ligaments in most people makes no difference for redraping. And you know this because you could look at all the people's photos who do facelifts with mandibular ligament cutting, and they still have an indent there. The only way to fix it is to really put a little bit of fat grafting there and treat it at its source, which is atrophy. And it fixes the color too, which is the other part of the equation there. So you can do fat transfer to chin. I do it here very, very often. Here, if I ever do it, I do very, very little. You don't want to get big augmentation out of fat. You get a fat chin. What do I think of Morpheus 8? It's fantastic. What city and state is your practice? I was going to say Compton. That's where I used to work for years. And it was more fun than Beverly Hills. But I'm in Beverly Hills. Will you be at the aesthetics show? No, they didn't invite me. What about chin filler? That's what we're talking about. Surgeon for deep plane facelift in Montreal or Toronto. There's some good surgeons there. My favorite surgeon of all time is in Toronto, and his name is Andres Gantus. But you do have Sami Mubayed, you do have Phil Solomon, you got a lot of good surgeons over there. And then in Guel is the area. You have, you got Mike Roskis, you got Matthew Brace, you got like amazing guys over there. So they're actually all in and around Toronto. And then one day the Cupid Center is going to be in Toronto as well. How to start treating vertical lines around the mouth. Most vertical lines around the mouth start in the upper lip, and it happens from SMAS depression before anything. And you know that because when they're relaxed, there's no wrinkles. If there's no wrinkles in the lip when they're relaxed, it's not a dermal problem, it's a subdermal problem. And it occurs when you pucker your lips because the skin, the support system is not there to support it. And when the muscle contracts, the skin doesn't just move normally like this, it indents immediately because there's nothing under it supporting it. The skin is a very nice organ to have because it protects you from the outside, but the skin is supported itself by hypodermal fat and SMAS in most situations on the face. So if you don't have those, the skin doesn't work so well and it falls inward. So the first thing you have to do is add volume back in over there. You do that by stimulation with nanofat, or you could do it with filler, and fantastic. Will chin implant lead to long-term bone resorption? It can. Is facial scarring from cancer removal a year ago a permanent scar? This, I'm not sure. Okay, I think we got all the questions. Fantastic. Hey! Kami Parsa is here. So anybody have any questions for Kami? Kami, would you answer some questions?
Hi, everyone.
We're doing chin.
What is this, live action going on?
Yeah. Do you see I was showing him how to use the light?
Yeah, there you go.
I know. So,
Hi, everybody.
Yeah. So, do you have any questions for Kami here, you guys? Anything? Please tell me and Jennifer to give me an appointment.
Yeah.
Have you heard of collagen implant? What's a collagen implant? I don't think
How do
I've
you read this? I can't read any of
Oh,
it.
because we're getting blinded by the light.
That's
that song. I'm blinded by the light. Yeah. Do you not release ML and DPFL? Is that double penetration? What's DPFL? Oh, D-plane facelift.
Yeah. I do really good.
Yeah. I release it sometimes, yes I do. But I release minimally because it bleeds a lot, so you just need to inflate it with a little fat grafting. So they say come to DC. Is anyone single? That guy.
That guy.
Not those guys. Oh, Nicole Andrews, who's a friend of mine, wants her mom to get an appointment, so...
I would love to see her. Awesome.
Fantastic.
Yeah.
All right, thoughts on stem cell ejections? They're fantastic. Can fillers cause permanent staining? Dr. Kami, underneath the eyes. Tyndall, can you get permanent staining from these fillers under the eyes?
It's very difficult to get permanent. I haven't seen really permanent staining. You know, the Tyndall usually resolves once you dissolve it and tighten it up. So, but I haven't seen permanent staining with fillers in that area.
Yeah. Nobody has any questions for Ritu Chopra.
Just how cute I am.
Yeah. When are you going to be in Toronto? Soon. Hi from Toronto. There's a lot of Toronto people here. The Canucks. Happy Canada Day last week. Did you guys say Happy Canada Day?
Oh, that's right.
Yeah. It was, Canada Day is great. Yeah, I always call their president Wayne Gretzky. They're like, oh, is that our... I'm always like, I know you're a president. Huh? Okay, fantastic. Well, I hope everyone has a fantastic day. Surgeons in the NorCal area, Sacramento, there's so many good ones, but I always sent Evan Ransom, Sachin Parikh, Dave Lieberman. There's a lot of good guys, but those are my favorites ever. And fantastic. So I hope everyone has a great day, and I will post this. And I hope everyone enjoyed my chin. Oh wait, can you show them your chin? Yeah, we gotta see Chopra's chin. We're doing a chin talk.
Oh, yeah, my chin's
So
a long chin.
it's a beautiful chin. It's strong.
Very.
Yeah, it's a sign of masculinity and
Virility.
and manlyhood.
Yeah.
Next to the Freddie Mercury poster there. It's fantastic. All right. Hope everyone has a fantastic day. Custom implant versus off the shelf, either one's fine. You can carve them, but most women don't need the regular implants all the way in, and most surgeons put them all the way in, like the long tapered ones. You have to really cut them and taper them yourself. Fantastic. Oh, tell us about your boat. It's been 3 years in the making. First of all, it's only been like 2.5. So,
And then it's going to sink.
It's not going to sink. It's
has a hole in it.
it's unsinkable 6. It is fantastic. All right, everyone, have a fantastic something.